Okay, hi everybody. I'm sure most of you know me. I'm Yana. I'm from Helen ED. And Tammy asked me if I could cover our death in the ED talk with you guys. We did it recently at Helen as well. And I try to sort of do it at the beginning of every year because we have a lot of new people and not everybody has filled in a death certificate before, and the paperwork can be quite daunting, but it actually doesn't need to be. So we all quite good at resus. We know exactly what to do. We know how to achieve ROSC, but we often after the resus tend to just sort of take off our gloves and walk away and leave things for the nurses to sort out. And we should actually also have a good idea about what is needed and what is the process after death, both for our own knowledge and also so that we can speak to the family and sound knowledgeable. A lot of families will come, and once you've broken the news to them, they will ask you, okay, so what happens now? And I think a lot of us tend to say, oh, well, the nurse will come explain everything. And if we just have the basics, it just makes for a nicer conversation. The family's on board, they've got the information. So it's important. So, what should happen next? The first thing is that we're going to declare the patient dead. We're going to inform the family about the death and counsel them and answer all their questions. The nurses will usually prepare the body, and then we need to do the paperwork. And this talk is really mostly about the paperwork. Okay, we're just going to touch on when is the patient actually dead. And the short answer is the patient is dead when you say so. Okay, medico legally, when the doctor declares either brain death or circulatory death, so either you've done brain stem testing and the brain has been declared dead, or you've checked for circulation and there's complete circulatory standstill, then you declare the patient dead. And they are legally dead when you have said that they are dead. So that's quite important to document in the file and to also know how to do the different death declarations and what exactly to look for. And that's actually an entire talk on its own about brainstem death testing and so on. So we're not going to go into a lot of detail, just to be aware that actually legally, as soon as you say the patient is dead, they are dead. Okay. Then we need to break the news to the family. It's very important that we try and do this in a private space. An ED and every hospital should generally actually have a dedicated counseling room. Unfortunately, a lot of places don't, which is really sad. So find a spot where you can get some privacy for a family, ideally a private room like an office or a space that nobody's going to just storm into, and gather them all together. You need to find out exactly who is with you there and find out what their relationship is to the patient, and then break the news to them in simple terms. Okay. Try and use clear language like he has died versus he's in a better place, or he's gone where we can't follow, or, God has come to take him. There's a lot of very vague terminology that people use. And actually, the clearer you are, the more straightforward you are, the better it's going to be. Remember, a lot of our patients are not necessarily first language English speakers, so you might have a bit of a language barrier. Plus, they might not hear very well what you're saying because this is a really terrible moment for them. So they might be very upset. They might not be listening properly. They might hear what they want to hear instead of what you're saying. So please be very clear with your terminology. Okay, you can explain how the patient died in simple terms, and then you can ask if they've got any more questions for you. Okay, it's also important to ask if the family would like to view the body. Some families do, and some families don't. But before you take them in to see the body, please make sure that the patient has been respectfully covered, that the patient has been cleaned a little bit, that there's not blood on the floor or medical equipment standing around or lines trailing out. So just do the minimal preparation for the body. Make sure that they're covered with a clean, tidy sheet. The eyes have been closed, and then you can bring the family in to view the body. Okay, remember, this might be for most people the last time that they see the body unless they have an open casket. So it's important that this isn't a horrible traumatic memory for people. So please be a little bit aware of that when people are viewing the body, and especially if it's a child that has passed on. Okay, this is going to be the most devastating moment for any parent ever. So try and do what you can to minimize the trauma. Okay. Then, once they've viewed the body and you've explained everything, you can ask if they've got any special wishes regarding burial customs or organ donation if it was a brainstem death that you've declared, or potentially still tissue donation even after circulatory death. Yeah, but you don't need to rush those kind of questions. You don't need to make sure that everything gets sorted out immediately. Give them a little bit of time, give them a little bit of space, and then see if there's anything that they would want or need from you as the healthcare provider. Burial is very important for most people. It's actually one of the oldest human rituals. It dates back to Neanderthal times. There's been graves with bodies that have been decorated with flowers or buried with a special object for around 100,000 years. So, this is really one of the oldest human customs, and we need to treat it with respect. Okay, death is sadly every day for us, and we need to carry on and go see the next patient and do the rest of the shift. But for the family, everything has stopped now. It's an important thing for them to get closure, to be able to bury their loved one as they want. So try and take that into consideration as much as you can. Okay, in South Africa, we obviously have many different cultures and traditions. For the majority of Muslim, Jewish, and Hindu families, burial needs to be happen as soon as possible. And where we can, we'll release the body as soon as we can. If it was a natural death, it was a forensic death, and the patient needs to go for post-mortem, then these customs unfortunately cannot overrule the medico legal implications. And we'll talk a little bit about it now. Um, Christian families, it's often not as urgent. The burial can take place in a few days. It's often on a Sunday. And then amongst our African patients, there's a lot of different traditions. There might be Christian patients, Muslim patients. Some families might want to involve a traditional healer or come to do a cleansing ceremony where the person died to come and collect their spirit. So please be sensitive to these kind of things. We've often had cases where families will come a few days later and they've brought their spiritual leader with them and they want to come and do a ceremony at the place where the person died. And that's totally fine. We try and accommodate them as much as we can, obviously within the confines of our space. Just one thing to be aware of, a lot of people want to light candles where the person died, and that's unfortunately a big no no because fire and oxygen just don't mix. Okay, so explain to them what's possible, what's not possible, that we might need to ask them to leave suddenly if another patient comes in, if we need the resus bay, but we do try to accommodate things like this. Okay, then our nursing staff will usually prepare the body. They will identify the patient with a mortuary tag on the hand and on the foot, and then a third tag on the mortuary fridge to try and avoid mix ups. It's very embarrassing when the hospital has released the wrong body to a family or has buried the wrong body as a pauper. So it's very important to make sure that the body is properly identified. Then there's a death report that's completed by the nursing staff. They will clean the body, wrap the body, and inform the mortuary, and the mortuary will come and collect the body from the ED or the ward. And the family then needs to bring an ID in order to identify the body, and they will organize with their funeral home to come and collect the body for burial or cremation. Okay, and all of that is usually handled by the mortuary. Okay. Families can decide whether they want to do a burial or a cremation, and you can do both as long as it was a natural death and you are not concerned that there was any foul play. So if you're 100% happy to fill in your death certificate, it was a natural death, the family might sometimes afterwards bring a cremation form and you can complete the cremation form. It's very long, but it's actually really straightforward. It just asks for a lot of detail around the patient's last period of life, which we usually don't have. And it asks quite specifically whether the patient had a pacemaker or anything else implanted in the body, because you can't do a cremation if there's a pacemaker still in the body. It can actually cause a big explosion in the mortuary. Okay, so the next thing that we need to do is the paperwork. And this is really so important, and we're often very bad at completing it. But one of the best ways that we can help the living is by counting the dead. And by that, I mean doing proper death statistics. So, if we can do the epidemiology and see what the leading causes of death are in our country, in our specific setting, in our socio demographic setup, then that can inform health policy going forward. It's really the only way that we can make the big health decisions about what we need to spend money on, where we need better interventions. It's one of the big drivers for the decrease in maternal and pediatric mortality. So, deaths under 5 have really dropped because we saw that a lot of babies were dying from gastro. And there's been massive worldwide campaigns to increase access to clean drinking water and to make sure there's proper sterilization and to encourage breastfeeding. And a lot of that was driven by death statistics. So it's really important that we do the paperwork properly. If you guys want to go read the Stats SA report, the largest comprehensive one that's out is from 2013. The 2023 census last year is still being processed, but it's very, very interesting to go and see what the morbidity and mortality causes in South Africa are. Just very briefly, in 2013, and this will probably change a lot with COVID and with better access to ARVs, I think our death statistics are going to look very different for the last 10 years. But in 2013, a large percentage of patients obviously died in hospital. A very small percentage are listed having died in the ER or as an outpatient. But I think that's just poor completion of the form, and I'll show you the relevant portion just now. Then small amount are DOA, nursing home. A lot of people actually die in their homes. So after a hospital, your house is the most dangerous place to be. And then at the bottom there, unknown or unspecified is 22%, which means a quarter of the death certificates were not completed properly. That's actually just bad record keeping. Okay, our leading natural causes at that point was still TB, then influenza and pneumonia or respiratory diseases, and HIV at number 3. And that is largely because HIV is usually a contributing cause, but not the direct cause of death. Okay, we all know patients don't really die of HIV, they die of the opportunistic infections. And so that would be the first thing that's listed, in this case, TB. Then we've got all of our non communicable diseases, our lifestyle diseases, which are really climbing across the world. And then intestinal infectious diseases down at number 8, which is gastro. And then chronic lower respiratory disease is probably majority smoking related COPD, but it's not specified. Okay, non-natural causes, other external cause of accidental injury, which is very vague, but it basically just means anything that wasn't an assault or a murder. Event of undetermined intent, we don't know what the cause of the trauma or the intention was. Then transport accidents, assault, and complications of medical and surgical care, which is a bit scary at number 5. A lot of people die from medical and surgical procedures. And then intentional self-harm at number 6. Okay, so then we need to go a little bit through the death registration process. So as we've said, the doctor confirms that the patient is dead, and they're dead when we say so, and then the patient must be identified by the family or with an ID document. So you need to make sure that the person that you're declaring dead is the same name that appears in the ID and the same name that appears in the file. Okay, we're going to complete the sections of the death certificate and the BI form, and we're going to go through that in a bit more detail. And then the last page of the form you can actually tear out, and it's supposed to be sealed and attached to the first copies of the other 3 pages. And that entire document then goes to register the death and to obtain a burial order. So that goes to Home Affairs. Okay, then form and complete section D, and that's usually done at the mortuary. And when the undertaker collects the body, they complete section E to take the body away. Okay, the informant then takes the whole tutti to the Department of Home Affairs, and they then issue the actual death certificate to say that the person has died. And it's really important to get that right, because without a death certificate, the family usually cannot access the patient's last will and testament. They can't distribute belongings. They can't access insurance like life insurance. So there's a lot of processes that rely on this death certificate. Okay, who should complete the death certificate? Ideally, the doctor who saw the patient, because you will have the most information and you're likely to be the most accurate. And you should do it as soon as possible after the event. Okay. Some mortuaries will not collect the body until they've got a death certificate. The patient should be able to go to the mortuary without it, but then they're going to come and hunt you down and ask you to complete the certificate, because everything else cannot happen until they've got that paperwork. Okay, all deaths then need to be reported within 72 hours, which we automatically do. And then we need to decide, was it a natural death, a non-natural death, or a DOA where you couldn't determine the cause of death. Okay, we need to decide if the patient requires an autopsy, and we'll talk a little bit about medical academic versus a forensic autopsy. And there's an entire, I think it's 150 page training textbook on just completing the death certificate. So if you guys are keen to go and read in way, way, way more detail, you're very welcome to. Okay, then we need to complete the form. And everybody calls this a BI form, but the official name is actually the DHA 1663. Okay, it's got 6 sections and it's needed in order to issue the death certificate and the burial order, and for a lot of claims and admin that happen after the death for the family, and then for accurate statistics for us so that we can make plans for future health care. Okay. Section A, and I know this is very small, but you guys all have this book in your unit so you can look at it, is just the particulars of the deceased. Okay, this is the patient who has died, not your own details. Every now and then I have to redo a form because a very tired doctor put their own details on here and declared themselves dead. Okay, so this is just the patient details. Please do it in as much detail as you can. I know we usually don't know the education level of the deceased and we don't know where they were born, but we can usually get the marital status from the file because it's information that the clerks collect. And if you can ask for some history from the family or before the patient passes on, then try and complete the occupation and the smoking history because that has huge public health implications. Okay, then section B is your details. Okay, technically a professional nurse can also do this form, but I've yet to see one do it, so it's usually the doctor. And you're going to state here in those first 2 blocks whether you think that the patient died solely and completely due to natural causes. And if you are completing this form, then the only box you should be ticking is the first box. Okay. If the patient did not die due to natural causes or you are not sure, you don't need to complete any part of this form. Okay, the entire form can be completed by the forensic pathologist when they've done the post-mortem. So this form is only going to be the first block that you tick, and then you're going to put your own particulars in there. Very important to put your HPCSA number as well as your facility practice number, and then you sign at the bottom to say that you've examined the body and you have determined that this death is most likely, as far as you know, due to natural causes. Okay. If you cannot be sure, or if you are definitely sure that it was an unnatural death, then you contact forensic pathology and the police and you complete a D28 form, and the body goes to forensics where the pathologist will complete all of the paperwork once they've done a post-mortem. Okay. The pathologist also has the discretion to do a full post-mortem or a limited post-mortem, or to just look through your notes, interview the family, examine the body, and decide that actually they don't think a post-mortem is necessary to establish the cause of death. But all of that is out of your hands. It is a legal requirement. Nobody can refuse to do a forensic post-mortem. The family's wishes don't come into it. It just goes to the pathologist. Okay, so what are some of the causes of unnatural death? So it's any physical or chemical influence on the body. So any trauma, any injury, whether it was accidental or intentional, any toxin that was ingested, and that includes medication side effects. Okay, so that would be a chemical influence on the body. For example, if the patient was over warfarinized and they died from bleeding from their warfarin, that's a chemical influence on the body. It's not a natural death. Any death that's very sudden or unexpected and we can't find a cause. And that's especially important in children who come in as DOAs. Okay, a child should never just drop dead. So those are all sudden, unexpected deaths for the most part. Any child where you suspect a sudden infant death syndrome, any procedure-related death. And it used to be that there was a time frame on this where it said 6 weeks since any procedure, it's a unnatural death. And they've changed the wording to that slightly. Now it is based on your opinion. Okay, so if you think that the patient died as a result or complication of any procedure, and that can be as simple as you put up a drip, the patient got thrombophlebitis, they got neck fash, they died. Okay, that is still a procedure-related death. So any deaths on table, any deaths related to IC drains, intubations, whatever, if the procedure was related to the death, no matter the time frame, it's still an unnatural death. And then any omission or commission, so that's action or neglect. And this is something that we see with elderly. So, elder neglect and child neglect can also be a cause of death. If anybody starves to death because nobody gave them food, the family didn't look after them, that's actually still an unnatural death. Okay, then section C is done by the forensic pathologist who does the post mortem. And if we don't know why the patient died, or we're fairly sure, but we're not 100% sure, but we're sure that it was natural, then we can still request an academic post mortem. Okay, and this is usually more to give the family closure than for any particular medical legal reason. Okay. If you want to request an academic post-mortem, that is done through the WITS pathology and anatomical pathology lab, and it is for natural deaths. Okay, so you complete the death certificate, you're sure that this patient died, or you think that this patient most likely died from a heart attack, but maybe it was a PE, and the family wants to be very sure. You put your best assumed cause of death on the BI form, you complete the entire BI form, and you do the WITS anatomical pathology form. You phone them and you book with the secretary, and they will tell you all the further arrangements that need to be done. And this doesn't cost the family any money, there's no payment, but there's going to be a delay for the burial. And the only cost that they might need to cover is that the funeral parlor or the undertaker will probably need to arrange transport from the hospital mortuary to VIT so that the academic PM can be done. Okay, so this is an option for family if they want closure, if you're not sure what killed the patient, if there might be implications for the rest of the family members like genetic diseases, then this is something that you can potentially offer them. Okay, then section G, which is really an important one. This is for the doctor who determined the cause of death, which if you've done the form, you are completing this. Okay, we need to list the sequential causes of death, everything that contributed to this patient's death. And then right at the bottom there, the block that's kind of your get out of jail free card at number 79, you don't have to be 100% certain. Okay, if we are declaring the patient dead, then we're probably going to mostly use block 79.4, which is opinion of the medical practitioner on duty. You are not the patient's regular GP. You were just on duty at the time the patient died. You declared them dead. Okay, 79.6, interview of a family member is very useful if it's a DOA that comes in. Then you can say, I spoke to the family. They said she suddenly had a really, really severe headache. One side of her body got weak. She collapsed and then she died. By the time we got to hospital, she was dead. That sounds like a very clear cut intracranial hemorrhage. You can say that you're basing your cause of death on an interview with a family member, and you can tick block 79.6. Okay. So in section G, we need to make sure that we're listing the immediate cause, the conditions leading to that cause, any underlying cause, and then contributing causes to give a complete picture of everything that was going on with the patient at the time of death. Okay. We don't want the mode or mechanism of dying. So cardiac arrest is not a cause of death. It's the mechanism of dying. No abbreviations because everybody uses their own ones and then nobody else knows what you mean. And as I said, a condition can be listed as probable, which is your best possible opinion. Okay, try and be as complete as possible. Grade the degree of the heart failure if you can. State it was an anteroseptal MI if you can. So try and be as specific as possible. Okay, we're going to run through a couple of examples. So you had a 75-year-old female patient. She had diabetes, hypertension. She'd had a previous MI. She presented with HHS, which resolved, but she remained anuric. Her dialysis in the ward was unsuccessful, and she died a week later with severe renal failure. Okay, so your immediate cause, the thing that killed her, was actually the renal failure. Okay, the condition leading to the cause was the HHS. So we're writing out hypoglycemic hyperosmolar state. The underlying cause which made her get HHS was diabetes, and the contributing causes was probably the target organ damage that she already had, as evidenced by the hypertension and the myocardial infarction. Okay, we have a 34-year-old male. He's short of breath. He has weight loss, diarrhea. He's HIV positive. He's diagnosed with PJP pneumonia. Initially responded, but then developed it again and died. So your immediate cause of death is still the PJP pneumonia. That is what killed him. The conditions leading to the immediate cause is AIDS. So if it's a really well-known concept like AIDS, you can write the acronym. But otherwise, write acquired immune deficiency syndrome. The underlying cause that caused the stage 4 HIV or the AIDS would be HIV or human immunodeficiency virus. And if there's no contributing causes, you just write none or you write a line through it. Okay, and as we said earlier, HIV is often the underlying cause, but not the immediate cause of death. Okay. If you've got a DOA, try and get as much history as you can because that's all that you will have to go on in most cases. Then please examine the bodies well for any signs that could help give you a clue to the death. Especially look very carefully for subtle signs of injury. Okay, if the patient is known to your hospital, try and get an old file, try and get a discharge summary, find a list of medications from the file, any letters from the clinic that the family may have kept, and then please complete some notes in the file so that somebody else can go through them and see what you found, a DOA form and a BI form if the cause is clear. So if it's a fairly obvious history, it's a patient who's had severe heart failure, they've had 4 previous heart attacks, they had typical chest pain that afternoon and they dropped dead, that's fine. You can declare that as a natural death and do the death certificate. Okay. If you're in any doubt, if the story doesn't make sense, if there's any signs of trauma, if there's anything to suggest that it was an unnatural death, then rather err on the side of caution and send the patient for a post-mortem. Okay. Please remember that the cause of death is actually supposed to be in a sealed envelope because there's still a lot of stigma around certain causes of death. Okay. Interns are actually not registered as independent medical practitioners yet, you doctors in training. So you can fill a death certificate, but it is not ideal. It's better for a senior person to complete it who's actually a registered medical practitioner. Okay, Cosmos, you are medical officers. You can do the death certificates yourself. And just remember that providing false information intentionally is fraud and you can be prosecuted. Okay. Making a mistake or being unsure, if it's done with the best intentions and in honesty, that's not an issue. Nobody's going to come and arrest you for putting the wrong cause of death. Okay. But if you're colluding with people to declare people natural death so that they can collect the life insurance and you're getting a kickback for that, then that is obviously fraud and you can go to jail. And people have gone to jail for massive death certificate fraud in the past. Okay, when should we stop? Okay, there's no actual fixed guideline for stopping a resus. It has to be individualized on a case by case basis. Nobody can tell you that there's a blanket rule that you do 20 minutes of CPR and then you stop on everybody. Okay, it's important to consider the underlying status of the patient. Were they chronically ill? Were they terminally ill? Are they a cancer patient with significant metastases? That's on palliation. What was their baseline state? Okay, if it was an unwitnessed arrest of unknown duration, that patient can probably just be declared a DOA when they arrive. If there's very obvious injuries that you cannot survive, then please don't start a resus. If there's no reversible causes found, the patient's already on maximum therapy, and there is nothing else that you can do, then CPR is not going to change that. And if there's been prolonged asystole, there's no cardiac activity on the monitors, you've gone through your reversible causes, there's still nothing to find, then those are all factors that you can consider to stop the resus. Okay. When should we not start? Again, it needs to be individualized and, if possible, discussed beforehand with the senior and family. And this is really for the patients who are critically ill in your ED, who have no disposition, are not ICU candidates. You need to have a discussion with the family about what they want for the patient and what they think the patient would have wanted in their dying moments. Okay, patients who are declared brain dead, there's no point in doing CPR. If the brain is dead, the patient is dead. And then, if possible, consider the patient preference. Find out if they had a living will, if they ever discussed this with their family, if they've got a do not resuscitate order, or if they've actually formally elected a healthcare proxy. And this is a legal thing that you can do to say, if I'm not in a condition to make my own decisions, I declare that my husband can decide when to switch off the ventilator or that I don't need to be resuscitated, for example. Okay. Consider not starting resus in terminal conditions where it's only going to prolong suffering and not actually bring the patient back to any sort of healthy state. And then always consider the quality of life that the person will have after life prolonging care. If you've had a absolutely devastating intracranial hemorrhage and you're going to be in a persistent vegetative state forever, and you're going to get bed sores and pneumonia and just suffer but never wake up, then that is potentially a case where you should not be starting CPR on the patient because you're not benefiting them. Okay, it's also important to discuss when we should be de-escalating. We always want to do everything for every patient, but sometimes you just can't keep going up. Okay, and it's always important to remember that just keeping a heart beating is not the same as living. Okay, it's got very similar conditions to not starting a resus, and it should never ever prevent you from giving patient comfort care. Okay, we never withdraw care from a patient. We might withdraw life sustaining treatment. It's important to explain to the family as well. We're always going to make sure that your relative is as comfortable as they can be. They won't be in pain. We'll continue giving them fluids. We'll wash them. We'll clean their nappies. We're not going to stop any of the things that provide them with comfort and dignity. But we need to now start withdrawing the life sustaining treatment because there's no benefit anymore. Okay, we must always consider what the reasonable prospects are for recovery within our specific system. If you've got all the money in the world, maybe you can lie in a coma for 10 years and then miraculously wake up, but it hardly ever happens, and it's not going to happen in a state hospital. Okay, we must decide what is in the patient's best interests, and this cannot just be the doctor's decision. It has to be shared decision making with the family members and ideally with the patient before they're in this condition. Okay, some patients might come with a living will. It's not a legally binding document, but it gives you a guide as to what the person wanted. Okay, and it can cover a lot of different aspects. It might say, I want intubation, but I don't want CPR. Or I don't want CPR and intubation, but if there's something rapidly reversible like a tension pneumo, then you're welcome to do the procedure on me. Okay, so it can be tailored to what the patient individually wants from their healthcare. Okay, this is just an example of living will wording that's available online. I would encourage all of you to make sure that you've had this conversation with your family members, that you know what they want, that they know what you want, and that you've got it written down and signed somewhere. So that if you're in this situation, it's not additional stress on family where one person says you must do everything and the other person says no, you wouldn't want that, and then there's an entire family drama surrounding the stressful time. Okay, we must all remember that life actually hurts a lot more than death. And what I mean by that is that it's the family that hurts after the patient has passed on. We must never forget that once our patient dies, the family actually becomes our patients as well. Okay, and that means that we need to treat them with dignity, with respect. We need to have an honest conversation with them about the death. We need to be able to counsel them and offer them further counseling if they need to, because they've just had the absolute worst day of their lives. I can promise you that. And we need to try and do what we can to make it as stress free and as atraumatic for them as we possibly can. It's never going to be nice, but it doesn't have to add to their trauma. Okay. And that is it from me.